Noon. Welcome. It is March 18th, Tuesday, and we're diving into, I feel like we did sort of healthcare 101, and I'm kind of hoping this is 201.
It might be PhD, but we'll see.
Cool, exciting.
We'll come out with PhD
And we
today.
have with us Kapel, who is going to give us an overview of healthcare economics.
Financing.
Financing.
Real economists will yell at me if I claim to know anything about economics. Okay, do I know anything about computers is the next question.
When you said, can I just say, you said a real economist, what is your training?
I have a master's in public administration. Actually, give me 30 seconds.
Oh, yeah, sure.
And then I was going to give 5 seconds of background.
Okay, great. Thank you.
It worked.
It's so funny. I don't know what's going on back there. Okay, let us move forward. He says, let us move forward. There. Okay, introduction. So I'm going to try to explain how money moves through the healthcare system, which is a terrifying thing. And I'm going to try to at least get you started thinking about what regulatory tools you have in place now. In answer to the question of history, I have a master's in public administration, started with the health department in 1978. Then I worked for Blue Cross, but I have no particular attachments to Blue Cross. The Healthcare Authority, if anyone remembers that. Vermont Program for Quality in Healthcare, Joint Fiscal Office, where I was either the guy before Nolan or the guy Nolan replaced. And then went out on my own as a consultant in another frightening number, 2007. So I've been doing this. It's a whole lot of working on this thing, talking about this thing, kind of on the job training, as less academic, more on the job sorts of things. But the joke that I've always heard is I want to work everywhere I can in healthcare that doesn't involve touching a patient. There's the man. It's you probably know. I believe Topper is the only person who remembers me.
Has he been here since 1979 also?
He's been here almost as long as Rich Westman.
Okay.
Steve did a lot of work for me. So why this is actually not traditional economics? Classic economic transactions, there's a willing buyer and a willing seller, either of whom can walk away from the transaction. There is perfect information, definitely not the case. Benefits and costs are entirely within the transaction. We'll talk about that a little more. And there are always multiple buyers and sellers. None of them are true in health finance. Imperfect information, just as an example, people talk about price transparency. Price transparency isn't really worth a whole lot in the absence of quality transparency. And nobody's figured out how to measure that well and accurately yet. You have very concentrated markets, and you have this thing called third-party payers. Third-party payer is anyone who pays for my healthcare other than me. It looks kind of like this. So public or private organization, it could be Medicare, it could be Medicaid, it could be Blue Cross, it could be MVP, or probably a little more confusingly, it could be an employer. So there's this thing called self-insured employment, and that has a major effect on what you all can and can't regulate. If you remember anything from this presentation, remember this graph. This is why we need third-party payers. This is why we need organized ways to raise money. So imagine Vermonters lined up from the least expensive to the most expensive. The most expensive 10% are somewhere between 2/3 and 3/4 of all healthcare spending. So the rest of us are helping them to finance their care. These are the $1 million premature babies. These are liver cancer cases. These are things no one can predict, but these are things that have a huge financial effect on top of a huge health effect. One rule of my presentations, you are required to stop me and ask questions. It's not an optional thing.
Thank you.
Simple-minded picture healthcare. So the red lines are payments. So I make some payments directly if I'm uninsured, if I have a deductible or any kind of cost sharing. The household taxes go to the public payers, the premiums go to the private payers. Nice and simple, right? This is what it really looks like.
Can I actually go back 2 slides? You said interrupt you with questions. Just the graph of the top 10%, that 10% are responsible for 73% of the
Do I go backwards?
expenditures.
There, okay.
Do we have a sense of, and I know this is in the US population, but we hear an awful lot in this committee about our aging population that we have.
Mhm.
But we've also received testimony, particularly this year, that our aging population can't necessarily explain away our high cost of healthcare. And I'm wondering, do we have a sense in the top 10% or the 10th decile in kind of an age range?
It's a great question. So not in this graph, but I've seen this same graph for Medicare, which would be all seniors. I've seen the same graph for HMOs. I've seen the same graph from the 1950s. It always looks like this.
Okay.
The question about explaining our spending growth by aging, yes, that is a piece of it. There's lots of pieces. People have made careers on arguing about what's driving healthcare spending increases. The big factor, probably technology.
Fine.
Before you go too further ahead, I'm curious if you know at what point in history did the policy begin that we would collectively contribute to the greater good, which is what this is showing, that we're all putting money in so that if we have a safety net. So when it happens to us or our loved ones, that they get the help they need, although it's failing to do that, honestly, for a lot of people, but that's the intent. Do you know what point in history it shifted from like, I'm going to give you a cow for saving my wife, or whatever? Whatever people did, trading and bar, like when people paid out of like Little House on the Prairie, like the doctor came to the house and you could give him chickens and he'd, do the thing, that they did. What point did it shift from that to we're all going to pool our money into these companies that are then going to distribute the money to other companies and, when did that start?
A great question. Let me see if I can do it fairly quickly. So there's probably 3 routes that led to the current system. Route number 1 was lumber camps in the Northwest. And the employer would enter into an agreement with the local doc. I'll give you $5 a month to take care of my employees. And that ultimately evolved into Blue Shield.
Really?
Blue Cross, Dallas, Texas, during the Great Depression, hospitals are struggling to have enough income. The teachers union entered into an agreement with them to pay a fixed amount of money for labor and delivery. That evolved into Blue Cross. What produced the employer-based system was World War II and price freezing. So employment shortages, you can't raise your salaries to hire people. So it all has to be benefits. And some employer figured out health insurance would be a great benefit. Before then, it was kind of this niche product that some people bought and some people didn't. But that swept the entire employment market. And that would have been in the 40s probably. And then in 65, Medicare and Medicaid. And that's all the major building blocks of what we've got today. Does that help?
Yeah, what year, do you know approximately the year of the lumber camps?
Oh, that would have been probably the teens and 20s.
Thank you.
Sure.
I'm sorry, I'm gonna,
This is much better than me doing a presentation.
my grandmother was a teacher in Dallas, Texas during the Great Depression when she had my father.
Oh, wow.
So. At home. Exactly.
Okay, the terrifying map. Do we want to talk about this a little more? So basically what this is starting to show is that the different payers raise their money differently, spend their money differently, and that there are populations and providers, and some of what's in your regulatory toolbox affects populations, some of it affects providers, and those two things don't overlap perfectly. We'll take some more time on that in a little while.
Sorry.
I know how to complicate that even more. Throw a pharmacy on there.
You know, what I was going to tell everybody is things are left off of this pharmacy. Yeah, that would be a whole day unto itself. So insurance, everybody talks about insurance. Insurance is basically a way to manage risk. Risk is most often thought of as an event that you didn't expect to happen, but wanted protection against. But it's also about things not matching up to your budget. So if you're Blue Cross or MVP, managing risk is trying to align your premiums with your payments, your claims payments. And you have to develop tools when those two things don't line up exactly right. Health insurance is different, though. We sort of think of insurance. Health insurance is a totally different creature for a couple of big reasons. Most other insurance, car insurance, homeowners insurance, life insurance, it's a fixed benefit. The value of the car, the appraised value of your house. We will pay you what your policy said when you die. Health insurance is open-ended. We will pay for your care until you get to something like a lifetime maximum. But you can't know that your worst loss is going to be the $100,000 that the policy covers. Most insurance underwrites the individual. So they will look at your driving history. They will look at whether you've got smoke detectors. They will set your fire insurance premium based on that. That used to be a common thing in health insurance. It's not anymore. Vermont actually outlawed individual underwriting in 1991, I think. Turned the insurance markets upside down. But that's another one of those steps toward commitment to each other. Because in the old days, healthy people would get charged less than sick people. Community rating, another one-day topic, says everybody who gets the same product pays the same amount. And then most other insurance is catastrophic events. Health insurance is this interesting hybrid of catastrophic events and wellness. It's almost like your car insurance also covers oil changes and brakes. It's a lovely idea. It makes the math much more complicated. Self-insured private payers. Somewhere in the neighborhood of 200,000 Vermonters work for employers who say, I don't want to deal with an insurance company except for administrative purposes. I want to manage the money. So they assume either partial or full financial risk for the healthcare costs of their employees. For a real large company, that's a fairly predictable thing. For a smaller company, it gets less and less predictable. So more and more risk gets put on the little companies. And you will hear stories of companies who thought this was a great deal for 9 years and went bankrupt the 10th. So it's an interesting out. It's something that sounds really attractive. Is it a good thing? Is it a bad thing? It's unclear. The other thing about self-insured employers is you can't tell them what benefits to offer. You have the power to have insurance mandates in the private insurance market. You can't tell a self-insured employer anything because of this thing called ERISA. You ever want to go to a cocktail party and be a health policy expert, just say ERISA out loud. Everybody will go, ooh. Employee Retirement Income Security Act of 1974. It basically was a federal law intending to simplify pensions because state regulation of pensions was a total mess. But somebody said, let's do the same thing for health insurance. So any employer who says, I'm self-insured, not working through an insurance company, is exempt from regulation, except public employers. I don't want to go near that one. We'll save that one. Okay, public payers, everybody knows the big guys, Medicare and Medicaid. Medicare, generally seniors and folks with serious disabilities and end-stage kidney disease. Medicaid, primarily families, children, again, people with disabilities. There's also the VA, Indian Health Service, so lots of other smaller public payers. Medicare and Medicaid are the big guys. They are privately or partially or totally health financed. They are an entitlement, which simply means if you meet the requirements, you're in, as opposed to somebody who says, I can do 50,000 people and that's it. So entitlement in terms of enrollment is open-ended. And both Medicare and Medicaid set their own reimbursement. They do not negotiate, they just say, here it is. Two kinds of providers. For regulatory and billing purposes, there are institutions, hospitals, nursing homes, things like that, and there are professions, doctors, podiatrists, physical therapists. What's happening more and more is those are aggregating into something like UVMMC, which is both a hospital and a provider, all under one organizational roof. Okay, now the fun stuff, he says. So you get to pay for healthcare. Lucky you. There's three main ways of doing it. For years and years, there was fee for service. I took your tonsils out, you give me $500. The problem with that is it's got a built-in incentive to take out lots and lots of tonsils. Actually, some of the earliest research on health utilization was done in Vermont about tonsillectomies. And it turned out there was a doctor in central Vermont who never saw a pair of tonsils he didn't want to take out. Total outlier. And he went on doing this for years because doctors had a lot of autonomy. One of the ways to try to get around that problem of what's called induced utilization is called capitation. Capitation is a fairly common thing nowadays, and it basically says, I don't care how much you do, I will give you a fixed amount of money for each patient you assume responsibility for each time period. So all of a sudden, the incentive to do more goes away. The incentive, it is hoped, is to keep your patients healthy. That sometimes works.
What? Go ahead. Go ahead, Bryce.
You said it sometimes works?
Yeah.
I'm curious, if it sometimes causes denial of care. I'm trying to think of a simple way to say that. In other words, like you would think where the motivational incentive is you'll keep people healthy, but could it be I'm just going to have a tighter schedule and see less people, and if I'll have a long waiting list, that kind of thing.
It is at least a perception that that is a problem. There is some evidence. The real challenge is that we have a financing system, fee for service, which incentivizes overuse. Are we going to trade that in for an incentive system that incentivizes underuse? So the real challenge is trying to find a payment system that actually tries to keep people healthy. It pays providers to keep people healthy. Could that work? Maybe, if we can figure out all of the factors other than the provider behavior that affect the health of the patient.
Can I ask a follow-up question?
Yeah, go ahead.
Has anyone ever considered paying the patient to be healthy?
That you ask that. I had an idea once upon a time that negative deductibles.
Yeah.
So instead of you paying $500 to get the thrill of a colonoscopy, we'll give you the $500 to get the colonoscopy. I'm not aware of anyone who's actually implemented that, except in the form of some wellness programs that will give you a small cash payment or a prize or something for doing healthy behaviors.
There is one example that Vermont is exploring. It's called contingency management. It's in the opioid abatement fund bill that's coming. And in contingency management, it uses an approach called motivational incentives. And you basically pay a person to stay clean from a substance. Mm-hmm. And the amount increases over time. And it's one of the only, I think it's one of two evidence-based practices that can work for psychostimulant addiction right now. And so it made, when you were saying this, I was thinking like, oh, well, that's one case where we're paying people to be healthy because it's cheaper than everything else involved that I'm not going to get into because this is not my presentation. But I was curious when you said that. That's all. So that's the only thing I can think of.
Yeah, I think that gets you into this interesting place of cost effectiveness. Paying everyone is probably not going to save you any money at all because you're probably paying a lot of money to the people who are already doing well. In your example, you've got the audience that you want to pay.
Yeah. So
it's definitely something to think about, but it would be kind of a bear to actually do.
Yeah. Thank you.
Oops. I'm not going back. So just to throw some big money numbers around, 2020, about $6.4 billion spent for care of Vermonters. So this is the first place we're going to start recognizing that the Vermont population is not the Vermont delivery system. About 2.2 billion of that is hospital care. Same year, about 6.8 billion was spent on healthcare in Vermont. So the difference partially is people coming from New York for tertiary services on the West Coast, leaving Vermont to go to Dartmouth for tertiary services on the East Coast. So that flow leaves you only the people who stay home for care that you really have 100% control over. You can't tell Dartmouth what they can charge. New York can't tell you anything. So just that's something to keep in mind whenever you're thinking about cost containment or management of any sort, that you've got this non-overlap problem, which looks like this.
Topper?
Steve, did I miss it? Did you talk about global budget and capitalization of global budget?
I was going to, and then I hit the go ahead button too fast and I forgot how to back up.
Hit the arrow, the back arrow.
The back arrow.
I think that's what Nolan did.
I am so glad there's somebody around. There we go. Okay. So global budget is basically the idea that you are Montreal General Hospital. Notice the selection of a Canadian hospital. Your budget is $13.25 billion. We're going to give you $13.25 billion. It doesn't matter what happens, that's your budget. That is probably in terms of controlling spending, the most effective of all. How it would work in the US situation with multiple public and private payers and border crossing, I don't know for sure. It's possible, it's not easy.
Do they also say, here are the services that you must provide?
Yes.
So the accessibility issue, I'm assuming, is addressed.
There's lots of different takes on US versus Canadian systems. People who defend the US system will talk about wait times in Canada, which is one of the way to manage utilization. People in Canada will talk about, look, everybody gets coverage. So that's why you guys get the big bucks. Okay, this is just a visual of the overlap problem. So, we who get care here, who live here, are the green, I don't even know what we call that shape in the middle. This is also the way the Green Mountain Care Board's expenditure analysis is organized. They do both of these separately, the resident budget and the provider budget. And you can look at them and wonder, well, what's the overlap? We don't know. Another one of those, I wish I had more data situations. Oh, now you don't want to move.
I wonder if that shape would be called a nexus.
Oh, God. No. Sorry, that was fun.
It's a connection between two emotions.
Come on, go ahead.
Maybe an inarticulable.
What is the fee for service rate to treat my PTSD?
You're trying to
I'm trying everything and it doesn't seem to want to move.
Click on the
It sounds, it's like a metaphor for where we're at in history.
It's a wonder they trust me with this sort of thing. Okay, application windows. Stop doing that.
Yeah, I hate when it does that. 'Cause I'm like, what is it gonna show people? I'm afraid I'm gonna cause vicarious trauma if my to-do list appears.
Got it.
That's a cool picture of a house.
There you go.
Seriously.
Yes, sir.
Why didn't you?
Technology gods. Yeah, that's actually my house.
Really? Is it like 200 years old?
Yeah.
That's cool.
It is cool.
And I stand out in front of it and do presentations. And somehow we got all the way to the end.
I like to take a deep breath.
Okay, yeah, we just talked about that. Take a deep breath because now we're going into regulation. So basically, it's a plumbing diagram. The money goes here, it splits off here, it comes back together. But in order to regulate the system, we need valves. So you guys have tools, insurance premium regulation. That's a big one, but that is limited to people who buy commercial insurance. That's one of those places where the self-insured don't get involved. You have hospital budgets. You can regulate their charges. You can regulate their net revenue, and you can regulate their expenses at that aggregate level. And then you have certificate of need, which is basically the state's ability to examine major capital proposals and approve, modify, or disapprove them. So when the hospital wants to build a new wing, it goes through certificate of need. So again, you have insurance premium regulation. About 90,000 Vermonters are affected by that. Hospital budgets, Medicare and Medicaid, again, don't pay charges. So when the Green Mountain Care Board issues orders to up your charges, down your charges, it only affects the commercial guys. And certificate of need is only the big projects. Okay, this is my favorite. It took me a long time to make this slide. This is where you have controls of some sort. You have no controls over state payers. You have no control over Medicare. You have total control over Medicaid. Don't worry, the next slide will explain this one. Yep. So the fully insured folks, you control the premium. State share of Medicaid is set by the budget. State funds for Medicaid come all sorts of ways. I don't even want to go near that one. Medicaid sets its payment rates. Medicaid tells hospitals, we will give you $743 for a tonsillectomy. And then you can control aggregate revenue and costs at hospitals. It's kind of a limited toolbox. I think that's the other takeaway. Because that flow is so complicated and there's so many different ways the money can move, then trying to get a nice, straightforward, simple regulatory model to live on top of that is almost impossible. And as mentioned, we omitted several other additional channels like payments to insurers, to pharmacy benefit managers, reinsurance, and reform models such as ACOs.
May I ask a question
I think so.
about the explanation of valves slide, which was a couple of slides back?
Yeah.
You know it, or do you want to see it?
I see it in my nightmares.
Okay, I figured you know it.
I'm just thinking, and you may not know the answer to this. So we have 14 non-profit hospitals in this state.
Yep.
They must accept Medicare. They must accept Medicaid.
I believe so.
There's no contract negotiations between Medicaid. Here's the rate. We're gonna pay you $748 for a tonsillectomy. You have to provide tonsillectomies. Here's how much you're gonna get.
I'm trying to remember if there aren't discussions with Medicaid.
Okay, I'm wondering if through BISCA, or what used to be BISCA DFR, do we have mechanisms in place where hospitals must contract with commercial insurances?
Yep.
Remind us what BISCA is. Well, BISCA was before Green Mountain Care Board and part of DFR.
Yeah, it was the healthcare authority got
Banking and
merged with banking and insurance to create BISCA, and nobody knows what a BISCA actually is.
I'm just, I'm thinking about, sometimes we often see in the news where there'll be this like dance between an insurer or a hospital when they can't come to contract negotiations and over rates or allowed amounts, whatever, contractual amounts. I'm just wondering if it was a requirement that you contract with payers, commercial payers, whether or not that would actually allow commercial payers to negotiate from a position of power, as opposed to right now, because we are such a small state and we have such limited services, it's almost where the entity is contracting from the position of power. I mean, you can't just say, well, we're not going to participate with Blue Cross Blue Shield of Vermont because everybody's covered by Blue Cross Blue Shield of Vermont and they're the only game in town for various regions. I don't, it's just thoughts swirling in my head around that. And I didn't know if there are mechanisms that forced negotiations and that you couldn't just say, oh, well, we're not going to participate with you if you don't give us what you want.
Well, I think if you are forced to participate, it's no longer negotiations. You know, one of the things about negotiations is I can get up and walk away. And there are reasons that are beneficial to the provider to contract. There are reasons that are beneficial to the provider to not contract. And part of the negotiation is both sides weigh those two things. And I think at that point, I will defer to Sarah for any further opinions on that one.
It just seems like when we're talking about a nonprofit, which is a facility or an organization that has been set up for the public good, that there are contract negotiations, and in a contract negotiation, either party has the ability to walk away. But in the case of Vermont, neither party really has the ability to walk away.
Yeah, there's a lot of concern, I think, nationally about providers aggregating, like the Boston situation, and then payers aggregating. So they're both getting bigger and bigger and more powerful, which pretty much means it gets almost to that point you're asking about where they're stuck together. But maybe to help you think about it, one of the things that happens is the provider agrees to take the contractual amount as payment in full. So simple case, I'm Blue Cross, I negotiated 10% discount. I agreed to accept that payment as payment in full as part of my contract. If I'm not contracting, I can then turn around and balance bill the patient. So everybody kind of wins. You know, Blue Cross wins or MVP wins because they don't have a collection problem. They get paid fast, but they have to give up some of that money. But then you get into the fun world of, okay, if I'm going to give you a 25% discount, I'm going to raise my rates another 15%. And I'm sure there's been a couple of dozen PhDs written on exactly that process, and how it works and how it doesn't work. I don't think I answered your question.
No, I'm not even sure I really had a question. Just, you know, I mean, for what we do with Medicare and Medicaid, which is essentially you must accept Medicare and Medicaid. You cannot balance bill. And here's your rate. Which
I'm not sure, and I will put this one up to anybody who knows, that Vermont requires providers to contract with Medicare and Medicaid. Because there are a lot of dentists, I'm sorry, who don't contract with Medicaid.
no, I was thinking specifically in terms of our hospital.
Okay.
You know, just our hospitals. Thank you, though. I'm not sure it was really a question.
Okay.
But you're just asking, where do they have leverage? Right?
Yeah, and if we've created a situation in the state of Vermont where one party has more leverage than the other. Because, you know, our Medicare rates, Medicaid rates, they are not going up as steeply as our commercial rates are going up. And it seems like there's very little mechanism and an imbalance of power in the commercial market. Oh,
That one for one last second.
yeah. Oh, Sarah, did you want to just want to chime in and then Daisy?
Sorry, Sarah Teachout with Blue Cross Blue Shield of Vermont. Just one more thing to consider in your discussion is that insurers are required to have network adequacy, which means we have to, you know, have in our network of providers for all of our members, just to have good access to care. And essentially in Vermont, that means we have to contract with almost every major provider.
Basic. I'm just curious if there's any parallel between, you know, what Alyssa's saying about lack of leverage and they're not another parallel could be the lack of MCOs in Vermont and the lack of competitiveness. And just what are your views on that competition kind of driving a healthier market?
I've never had a real good sense of how competition works when there's like two providers and three payers. You know, they all have huge shares of the market. I think one of the interesting questions in the negotiation process is, can you, the payer, move your patients? If I decline to contract with you, do you have the capability of saying, okay, I'm going to send all my patients to this other hospital? And that's never really been demonstrated in Vermont. So it's a really strange and complex negotiation process.
Which, almost Sarah's point, which is they're required to have network adequacy. Which then puts another cap on them from being able to negotiate certain ways. Anyway, thank you. Thank you for indulging. Oh, Leslie.
Interesting. I've taken a deep breath,
Okay.
a lot, many times. And you've set out the problem. And now what do you suggest we think about?
Well, partially, I've been doing this 40 years, something like that. And the longer I do it, the less sure I am of what the answer actually is. But I think something to think about is the idea that everything we talk about as healthcare reform is in one way or another a technical fix. We don't seem to want to talk about the moral questions. And I would argue entirely my own private opinion, you can't solve a moral problem with a technical fix.
And the moral question is,
Who's entitled to healthcare? What does it mean to be entitled to healthcare? How much of healthcare is an entitlement and how much isn't? Or are you on your own?
and how would you imagine having that conversation?
I think that's for you all to figure out. The one thing I always find, the one extraordinary conversation I am aware of in health policy was the state of Oregon, maybe 30 years ago. They decided it was crazy to have Medicaid eligibility depending on the budget. So one year it's 105%, the next year it's 113%. We had a bad year, it goes to 90. So they decided they wanted to prioritize care. These are the things everyone should get no matter what. These are the things not so much. And they wanted to manage their Medicaid program by moving up and down that list. And it failed completely. But it was at least a conversation about, is all healthcare the same, or is some healthcare more important than other healthcare? That's kind of what I mean by a moral question.
Why did it fail?
It failed for the technical challenge of ranking things. When people saw the ranks, weighing a liver transplant for a 12-year-old against 5,000 vaccinations, people didn't like how that all worked out. And then the federal government, being the federal government, just said, well, no, you can't do that. And that was the end of it. But having that conversation was an amazing thing.
Yeah, that would be very cool.
We're not doing that, just go. I am not asking this committee those questions and coming up with the answers of pitting.
But just the moral conversation, not that solution.
Vaccines tougher.
Back to the moral conversation.
Thank you, Topper.
Are you familiar with the Rochester experiment on global budgeting?
Yep.
Okay. I thought that was a pretty good one, as you well know.
Mhm.
And it failed because of greed.
It failed for a couple of reasons. Greed among
One of them was greed.
No, I think without going all the way into Rochester, it was a very local project that had the cooperation of 2 or 3 huge employers who had the influence to swing that kind of a thing 25 years ago, 30 years ago. I don't even know, it also died. It may have been greed. It may have just been a lot of reform models seem to work for a while and then the effect wears off. I don't know quite why that is. But, this is not to say by any means there's no way to solve this problem. It's to say by all sorts of means, I have no idea how to do it.
It proved that you can do it,
Yeah,
but everybody has to be on the same page for it to work.
yeah. Oh, and actually, let me add one more thought on moral questions. Moral questions always imply a trade-off. Technical questions always imply improved efficiency. So we're just trying to get all the efficiency we can. And I don't think we're going to be able to find enough, given the incredible technological things we keep coming up with. I was just talking to someone about autoimmune diseases. And there's a gene therapy fix for autoimmune diseases, which is amazing. Costs $250,000. Do we do it?
Yes.
Okay. But we talk a lot about administrative costs, which are kind of ridiculous. We talk a lot about different reasons why healthcare costs are going up so fast. But at least one of the big ones is we're really clever. We have an amazing capacity to figure out solutions to complicated health problems. How do we manage that? Now that I've thoroughly discouraged one and all, further questions, further thoughts?
Since there was some space and.
Yep.
I'm like, you know what, why not? I noticed that in your presentation, we didn't really talk about what happened from 2011 to 2014.
Which one was that?
That was Act 48.
Ah, that one.
And it sounds like with your experience, you lived through it. I'm curious, like, if you have anything to say about then versus now. I lived through it, but I'm not an economist either. What I recall is there was studying done that looked at various approaches to implementing Green Mountain Care, public, private, et cetera. And then there were numbers projected. And what I remember from the numbers, which could be skewed and biased because it's been a while, was that it projected the premiums going up and it showed how for lower and middle income people, it would be a better deal, but for people who make more money, it would be a worse deal. And then the governor pulled the plug on it. And I'm curious, like, when you look at those projections to now, I think we're higher now. Like, I feel like it did not, like, in other words, like, we didn't gain any benefit in terms of premiums for the average person, but I could be wrong. But I'm curious from your perspective, like, what got in the way of moving towards a publicly financed system? And is it something that we might consider at this time?
So for folks who weren't around for that fun and excitement, that was Bill Shao. That was the Shao report. Full disclosure, I was working at Bill, which was an honor. And what seems to be the make or break point, having lived through several of these now, is the tax rate. People are convinced their employer gives them health insurance. They don't view it as they are foregoing income in order to get health insurance. And there's good reasons to do that. But people always add the new tax on top of the taxes they're paying now and the premiums they're paying now. And everybody does this. When the healthcare authority failed at it, I can still see the headline on the Burlington Free Press about $250 million in new taxes. It died that day. So until everybody really understands where the money comes from that pays premiums, they're going to view the tax as additional to that. And how you convince the employers to then turn what they were spending on healthcare into revenue or into income. There's another interesting challenge, but it fails on the taxes.
So can I just like reflect what I heard, make sure I'm understanding it? That a barrier is people's understanding of how the financing works, benefits versus costs, and that that in a publicly financed system, the burden of the cost would shift from premiums to taxes. And if we were going to explore a publicly financed system, it would be important for people to understand that there's a shift of cost from premiums to taxes, and showing them if that shift in cost is actually going to save money overall, because it may not. It could be that it shifts from an $800 a month premium to $1,000 more in taxes, and then we're paying more. But if it's from an $800 a month premium to $600 a month more taxes, maybe the average person saves $200, but everyone gets the benefit. And then the other piece is the employer piece, that better understanding how much are employers actually spending on the healthcare versus raising the wages. And that includes the public employers, like state employees and teachers, stuff, because that's driving up our property tax rates. So technically, if another angle might be like to understand, to show the taxpayers how we're saving the taxpayers money in general by paying our workers in the public jobs a little more, and then them paying more in taxes towards their premium versus us just covering the whole premium. And I'm sorry, I kind of got all detailed, but I'm trying to like conceptualize what you said, and I don't know if that's all correct or if anything I said was wrong.
Well, let's just keep the who benefits in a separate box, because who benefits and who loses depends on how the tax is structured.
Can you say more about that?
Well, if you think about, let's just say we're no longer calling them premiums, now we're calling them taxes.
Yeah.
Then someone at livable wage, just barely, is paying the same amount as someone who's got a law firm or something.
With the current premiums.
Yeah, premiums.
That's absolutely
everybody's
correct.
paying the
Yes,
same.
yeah, yeah.
So
Subsidies, yeah.
you can say that is a head tax. It's not a progressive tax.
Mhm.
Let's say you want to go to a progressive ISIT. What do the schedules look like? So you sort of can tune your winners and losers to some extent based on what policy direction you want to go in.
And right now, we're getting federal subsidies for many people like myself. I fell below the 400% poverty line for 2 years in a row and didn't get the benefit, and then got a refund, which was cool. But for the first 7 years, because I overpaid in healthcare, and it went from $800 a month to 8 cents a month. That's a huge difference, but that's a federal subsidy that's allowing that, and those are may go away in 2026. So we may be faced with a problem there. But I think what I'm getting at is your point is that that premiums and taxes are really tightly connected in the current system. And the Supreme Court even ruled that was okay with the Affordable Care Act, right?
I think so, yeah.
Yeah, they said like that. I remember John Roberts said something like that the government has the authority to tax, and that's how they're doing this, through taxation, and people need to face the consequences of their political choices or something like that. Like, he was like basically saying the Supreme Court's holding it up, and if people don't like it, elect different people, which happened. But
Maybe if I can just sort of put this all in a box to make it a little easier to think about. There's 3 ways to pay for healthcare. You can pay for it based on how much you use. You can pay for it based on your ability to pay, or you can pay for it the same amount as everyone else pays. Community rated health insurance. So somewhere in those 3 options, there may be a better blend than what we've got now.
thank you. You don't know what that is, or you would tell us, right? So,
Oh, don't I wish.
okay, thank you.
Topper has a question. I have a question, but before Topper asks his question and I ask my question, I just want to expand just a tiny bit on, do you think I mean, I remember, I wasn't a part of it, but I remember when all of that was going on. And, you know, the messaging got lost in, hey, you're already paying for this. Do you think though, the environment that we are in currently, that possibly the public perception may have changed a little bit? I do know myself personally, I was getting a raise every single year, and yet I was making less money every single year. And I think that's happening for a lot of people.
Mhm.
And, you know, the nexus between
Oh.
property taxes and health care, people are seeing. I'm wondering if you think that possibly we are in a different place publicly than we were even 10 years ago.
So there are two things I am genuinely terrible at. Basketball and understanding where the public is at on any questions.
All right, good answer. Topper.
Well, part of what you were just talking about, I noticed that hospitals now are asking for a global budget. They weren't several years ago when I was trying to get them to do that. I think personally, in order to move along to try to solve this problem, while we're doing the financial part of it, we have to structurally change how healthcare is delivered. We have to look at the hospital and utilize the hospital the way it should be utilized, and set up a system where you go to clinics. Maybe we don't need as many hospitals in Vermont, but we need more clinics.
Mhm.
And I think that that's got to be part of any kind of healthcare reform.
I think the Grafton Foundation, I think they're still around.
Yes.
They would have a meeting a year on different topics, and one year they did hospital care. This may have been the 70s. And they said 4 hospitals. Vermont needs 4 hospitals. And we just need to convert, exactly as you're describing, the other facilities into something different.
Yeah.
A lot of people think it's a good idea as long as it's not a hospital.
Yeah, but I think you could convince those people if you had the kind of express care type clinics that could take care of most things that an emergency room is now taking care of at a tremendous cost compared to what it would cost. I think that would be, and then you could figure out, you know, the how you're gonna finance the whole thing. But that would bring into everybody's attention the fact that you don't have to pay as much as we're paying now to get the service, because you're not going to that emergency room in the hospital. And you've global budgeted the hospital.
Mari. Oh, I'm sorry, Topper.
I'm done. I'm done.
I'm just adding to the discussion, and would appreciate Elliot Fisher's comments too when you're up in the chair. But thinking about public perception of our healthcare system, which I struggle to call a system. And I fear that there won't be much motivation by the general public to do something different, like one system, one actual system, not pieces that are fraught with problems every time you tug on one part of it. I fear that it's going to take the crashing of our healthcare system, which feels like it could be imminent, depending on if we do lose Medicaid, significant Medicaid dollars. What I see is loss of hospitals closing, clinics closing, lost primary care. Providers being able to function, people not being able to pay for healthcare. Deep recession, if not a depression, it's catastrophic. And I think because the healthcare patchwork that we have, and I'm just talking about Vermont now, is so hard to understand. It's gonna take a crashing for people to say, okay, we need to do something different. And I'm thinking about my time in house healthcare and a couple of legislators in particular whose political proclivities would have have them not support a universal system. Like the phrase Medicare for all to them was just a horrible thought. And yet these two very conservative legislators, after being through House Healthcare Committee and just being immersed in this stuff and seeing the pain and the frustration, these two individuals at separate times in different years threw up their hands and said, why can't we just have one system? So other than the system crashing and people realizing we have to do something different, then maybe we should make everybody in Vermont sit through House Healthcare committee meetings for at least
I have those days marked on my calendar when those happened, but
You do?
yes. Did you have a question? No?
No, it's just adding to the
Okay.
discussion, and I think that politics is part of the problem, in ideology when something is so hard to understand, and people are rightfully afraid and concerned, then it, taxes sound scary, because when taxes are too high, people suffer. So the word taxes has a political and emotional connotation, it's really hard to get past, even if the tax that you're suggesting really makes sense and will actually help people. Same with Medicare for all, universal healthcare. I think it just has, it's loaded, it's so loaded. Anyway, that's my speech.
Thank you. Any other thoughts, questions? Oh, I'm sorry, Daisy, I forgot.
Would you just indulge me and maybe go out on a limb to imagine a guess of how many hospitals Vermont might have in about 5 years? Your best guess. 5 to 10 years. I mean,
Putting them on
I'm getting a lot of trouble asking you, but answering that question.
Don't do it. Don't, you're gonna.
thanks, Leslie.
Somewhere between 1 and 14.
Yeah, exactly.
No, it's, what is a hospital?
Keep going.
There's,
Who asked that question?
Yeah, well-
We had that conversation, yeah. Woody asked that question months ago.
there's a creature called a critical access hospital. And Vermont has 8 of them. And they were intended to be more of that transitional thing, not a full service, we do open heart surgery hospital. Are they
We do
struggling?
not do open heart surgery. Yes,
Sorry.
definitely.
I'm not supposed to ask other people in the room, but yeah, everybody is struggling in healthcare now. It's just, the problem, okay, one last story. It's a guy named Church Hines, who is, he was a commissioner of finance in Vermont. He ran the home health agency in Burlington. He's got a PhD in health policy. And he was saying he got his PhD in the 70s and healthcare was 4 or 5% of gross domestic product.
Mm.
And everybody knew, all the experts knew if it went to 7%, the economy would collapse. Okay, maybe 10%. 12? 15. It's at 19 now. So people have been predicting the collapse of this crazy, incompetent, weird system for 50 years. And it just keeps going. How does it do that? I wish I knew.
What was that person's name again?
Churchill Hines is his full name.
Hines.
Yeah. H-I, of course, there's D.
I don't believe so. Guess they changed it names.
Amazing character.
I had one more question, but if anyone else has anything else you'd like to add. You've been around, you said, since 1979 in Vermont, working on various healthcare. So I'm sure that over those years you have seen lots of different ideas. This is going to fix it. Let's pivot to this. Is there anything that we've done in the past that you feel was a worthy endeavor that we just didn't either implement the correct way or commit to? Or do you see anywhere where we've had successes in healthcare reform?
I think one of the places we have had success is opening up what that definition is of healthcare. I don't think there's an easy, obvious, or even impossible solution inside the box of people in white coats with big buildings. What helps, I think, is what everybody calls determinants of health. Housing, food, education. One of the amazing successes in healthcare has been managing diabetes. And one of the reasons it succeeded is because everybody invested in diabetes education. So they are designated people who help folks with diabetes learn how to eat better, learn how to manage their blood sugar. And the death rate, the complications from diabetes, gone way down. Can we find other places like that with that nice, simple, here's an obvious thing we can do to fix it? I would think so. But I think stuff like that is going to be way more successful in the long run.
But you can't ignore technology in dealing with diabetes.
Right. You can't ignore technology in any of this.
That's sort of the point. Yeah, that's the thing.
Great. Well, thank you. Thank you so much for coming in.
Sure.
Sharing. Love your house.
Mhm.
I think we're going to take a break before we move on to Dr. Fisher. How about it is 2:16.